Joining the American Lung Association's discussion about lung cancer incidence, causes, detection, and disparities in Kentucky. I'm Shannon Baker, the Director of Advocacy for the American Lung Association in Kentucky, Tennessee, and Arkansas. The Lung Association released our annual State of Lung Cancer report earlier this month, which ranked Kentucky second best in the nation for lung cancer screening. So we've made some good progress to celebrate, but the report also showed that Kentucky has the highest rate of new cases of lung cancer in the nation, ranks 41st in the country for survival, and ranks 45th for early diagnosis. So it's clear that we continue to have a lot of work ahead of us in Kentucky, and key to our efforts, I think, is understanding and acknowledging that anyone with lungs can get lung cancer. And this discussion today is intended to embrace and explore and help us understand and address that reality. There's a lot of important territory to cover today, and we have some highly regarded experts joining us. So they will be speaking to our experience with lung cancer in Kentucky, touching on causes, research, treatments, disparities. And we also hope to have several minutes for Q&A at the conclusion. So in the interest of time and to facilitate the flow of our discussion, I'll take just a few minutes to introduce all of our speakers now, starting with Lindi Campbell, who joins us today. Lindi's a lung cancer patient and advocate. She's made it her mission to erase the stigma associated with lung cancer by educating others that, in fact, anyone with lungs can get lung cancer. She believes it's urgent we improve and expand our conversation to include discussions of varied causes and factors surrounding the disease, in addition to tobacco use. Lindi spends much of her time working with organizations dedicated to scientific research focused on improving lung cancer survival statistics for all. Also with us today is Dr. Tim Mullett, who is a professor of surgery in the Division of Cardiothoracic Surgery at the University of Kentucky. He received his medical degree and surgical training at the University of Florida, and he served on the faculty at UK for the past 25 years. Although he has experience in cardiac surgery and transplantation, Dr. Mullett's clinical practice and research focuses on the overwhelming burden of lung cancer in Kentucky. Currently, Dr. Mullett is the medical director of the Markey Cancer Center Affiliate Network, and in October of 2020, he was installed as chair of the Commission on Cancer. Kyle Hoylman, co-founder and managing partner of Protect Environmental, joins us to share his expertise in radon testing and mitigation. Kyle currently serves on the EPA Vapor Intrusion Science Advisory Committee and the EPA Radon Leadership Committee, which is responsible for developing the National Radon Action Plan. Kyle also chairs the committee developing standards for radon measurement and mitigation, serves on the board of the American Association of Radon Scientists and Technologists, and chairs Kentucky's Radon Program Advisory Committee. Finally, we have with us today Ellen Hahn, who is professor in the Colleges of Nursing and Public Health at the University of Kentucky. She holds the Marcia A. Dake Endowed Professorship in the College of Nursing. Dr. Hahn is director for UK CARES, which stands for the Center for Appalachian Research in Environmental Sciences. She also directs the Kentucky Center for Smoke-Free Policy and the BREATHE research team, where she conducts community-engaged environmental health outreach and research to reduce risk from tobacco use, tobacco smoke exposure, and radon exposure, especially in disparate rural, lower-income communities. So Lindi, if I may, I'll hand off to you first to help frame why our discussion today is so important and why the need for our collective awareness and action is so urgent.
Well, thank you for allowing me to start this off. I'm excited about our conversation today because when I was first diagnosed 4 years ago, I didn't know anything about lung cancer. I wasn't paying attention to it because I didn't think I could get it. Most people don't usually think about lung cancer unless or until they're diagnosed. So how can we get more people to pay attention? We have to help them understand that anyone with lungs can get lung cancer, right? Otherwise, what's their motivation for paying attention? When they begin to really believe that they or anyone they know or love can die from the disease, they'll pay attention. We must take opportunities like this to shed light on all of the fast moving pieces when it comes to lung cancer if we really want to improve the survival statistics for every single person affected. Because the majority of us who are getting lung cancer who never knew we could get it are not even given a chance to fight this disease before it's already spread to other parts of our body. Research and statistics have been showing us more and more that there are varied causes as well as genetic mutations that really don't exclude any of us. So those of us who are here today already know this, but does everyone else? Have we done a good enough job letting all of our citizens know that anyone with lungs can get lung cancer? It's always important to me whenever I hear someone talking about lung cancer that they're also thinking about the people it affects, the survivors, the caregivers, and those who pass away whose memories are still so important to their loved ones. I know what it feels like to hear this disease talked about and wonder if people really care. Do they really think about us and truly understand our suffering? When I was first diagnosed, I shared my story a lot. I desperately wanted the public to see that anyone they love could be a lung cancer survivor like me. I can't think of a better way to kick off our conversation today than by sharing a few stories of some of the fellow Kentuckians who represent the anyones who can get lung cancer. They're just a small handful of the Kentuckians I meet all the time who are living with and dying from lung cancer. So who can get lung cancer? Brittany from Hardin County can get lung cancer. I'll start with her because she's my newest survivor's friend and fellow advocate. She's a healthy 36-year-old mom with no known risk factors who was just diagnosed a few months ago. After battling COVID, she had a stroke, and while doctors originally thought it was due to COVID, further testing revealed she had stage 4 RET-positive lung cancer. It was determined the stroke was due to one of the tumors in her lung that was growing close to her heart. She just started treatment for this rare mutation. David from Boyd County can get lung cancer. A college sorority sister of mine, whose husband was diagnosed with stage 4 EGFR positive lung cancer a few years ago. He's a physician in Ashland, Kentucky with no known risk factors and was on the brink of death before he was finally diagnosed and is currently on a targeted therapy drug for his mutation. Kim is one of 2 college sorority sisters who have reached out to me to tell me their husband has lung cancer. Tom from Jessamine County can get lung cancer. He's in his early 70s, and so far his immunotherapy treatment is working well for him. He recently told a friend he feels guilty he can't quit smoking, but he said he's determined to continue trying. No one wants him to feel guilt or shame many feel when they're diagnosed with this disease, but we also understand the added health benefits to him if he quits. So his family continues to encourage and support his efforts. Elizabeth from Jefferson County can get lung cancer. She was my very first true friend I met over 2 years ago. We texted all the time, and she always found a way to make us laugh, even despite her pain and constant disappointments. At just 29 years old, she was diagnosed with stage 4 ALK-positive lung cancer. She passed away just weeks after her 32nd birthday. She was a former collegiate athlete with no known risk factors, and sadly, her body never responded very long to the treatments that were available to her. She leaves behind a loving husband who's now raising their 2- and 4-year-old daughters. He struggles every day to wrap his head fully around what has happened to the future they dreamed of having since they first started dating in middle school. Sheila from Lincoln County can get lung cancer. She was a retired teacher in her 60s who passed away last year from small cell lung cancer. We spoke on several occasions, and despite the poor prognosis and the struggle I could hear in her voice when she spoke, her attitude remained positive. But sadly, she passed away just a few months after her diagnosis. Chastity from Campbell County and Leah from Jefferson County can get lung cancer. I've known them both for several years now. We all share the same mutation-driven EGFR exon 19 deletion lung cancer diagnosis. They were both diagnosed with stage 4 lung cancer in their early 40s and each have 3 children. We all 3 believe known previous exposure to radon is possibly a contributing factor to our diagnosis. We're on the same targeted therapy treatment and are all currently stable, but can only hope scientific research will continue to develop precision medicine to treat our specific mutation when the cancer outsmarts the drug and starts growing again. Alyssa from Caldwell County can get lung cancer. She was diagnosed with stage 4 lung cancer at 38 years old. She was married with 2 school-aged children. She was a healthy cattle farmer prior to her diagnosis, but had an extremely rare mutation, and the only treatment available to her was a drug mostly used to treat melanoma. She passed away just after her 40th birthday. Shelby from Jefferson County and Cheney from Caldwell County can get lung cancer. I want to finish by telling you about the two youngest survivors I know who were just 27 years old when they were diagnosed with stage 4 lung cancer a few years ago. They were healthy, just starting out their families, each with 2 toddlers and still wanting more children. Both women have had another baby since their diagnosis, but can only hope more research and treatment options for their ALK and EGFR mutations will help them live longer lives to watch their children grow. It would take me all day to tell you all the stories I know of fellow Kentuckians who have been diagnosed with this disease. I just ask that today you think of all these people, their stories, their struggles, and their heartaches. Because when we talk about lung cancer statistics, those of us who have faced it head on really are what you're talking about. And any of our stories could be your stories or that of someone you love. Thank you.
Thank you very much, Lindi. Dr. Mullett, can we turn the conversation to you now to pick up where Lindi has concluded and to share with us your thoughts about the various causes and advances in detection and treatments for lung cancer, please?
Oh, thank you, Shannon. And it's so good to see so many friends on this call, and both participants, but also those that have attended as guests. And you know, this is a special time for me. This is Lung Cancer Awareness Month. We're at the tail end of that, and it's been a busy month. We've had a lot of opportunities to talk about lung cancer this month, and I think that's frankly to the credit of people like Lindi and sharing the stories that you've heard just recently, and that honestly puts such a face on this disease that's critical. And I think it puts a real face on this disease, because I think that you know, as you heard, I've been in Kentucky for 25 years, and it's my home now. But when I came here, I was struck by the burden of lung cancer that our population was dealing with, and so it became a passion to be able to work in this area, and a privilege to be able to take care of so many of these people. And I've seen, you know, if I think back to the talks that I gave back in the 90s and so forth, and the images of lung cancer and the images of patients that have lung cancer and so forth, they were stereotypical of a disease that didn't look like what you just heard about from Lindi. But as I got to know the patients that we take care of, we see the face here in Kentucky of a younger population that develops this disease. We see folks with risk factors that we describe, and we align risk factors with the disease, because as physicians, that's a way that we sort of categorize people and sort of put them into you know, what we consider a differential for findings of symptoms, or a way of putting in a list of diseases that they may have associated with their behavior, with their influence, with their exposure, with their family history. All of that goes into a mix that we put in. And so we assign those risk factors, but those aren't the only factors that develop cancer. And so, you know, when we look at those, and we can certainly understand that the majority of patients who have lung cancer have an exposure to tobacco. We understand that. We understand that Kentucky has led the nation. It's not right now. We're number 2 in the nation in terms of tobacco exposure in our state, and that's good. We're diminishing that, and as is the country. But it has such an overshadowing feature when it comes to the diagnosis of lung cancer that it kind of takes away what Lindi mentioned and what you'll hear about later about radon exposure, and that's a strong factor in Kentucky. And since we look at data by a state or by a region, we often kind of water down some of those effects that might be additive, where we might have some tobacco exposure, but we also have radon exposure. There's also heavy metal exposure that's been linked to an association with development of lung cancer. And I think there's also a family history that has not been as strongly associated as it has for breast cancer or some of the others. But I think that as we develop more knowledge about the genetic profile of this disease, then we're going to see that there's going to be some linkages. And so I think that we're beginning to put into place more of that. And I think that it's through advances in research that we are learning more about the genetic profiles of the tumors and how we can treat them. Targeted therapies are coming along for patients with late stage disease. And even in diseases like you heard, a patient with small cell lung cancer, one that's about 20% of the cancers that we see in the lung. It's typically a very aggressive tumor and one that carries a very poor survival. But with some of the newer treatments, we've increased the opportunity for survival by maybe 15%, whereas it was perhaps 5%, a 5-year survival in years gone by. And now with certain drugs, we're seeing that up to 20 to 30%. And so when we see those kinds of numbers, it is impressive to see that we can make that kind of a difference in this disease. And it's that information, and we're certainly seeing that in non-small cell cancers, the more common lung cancers that we see in late stage diagnosis with targeted therapy, and those that have the appropriate mutations that can be acted upon through the more efficient and more common utilization of the genetic testing that can be done for these patients, that should be done for patients that have lung cancer. Then we're getting into a territory that we've never been before, which is, what is the 5-year survival for lung cancer? We're changing that. And so we're beginning to see that we may not know, that when we may not be able to tell our patients what their 5-year survival is, because these new agents are coming along pretty fast, and new agents are coming in every year. And so I think, I mean, we've seen the pace of medicine change just in this COVID era, development of vaccines, development of other technology, and the new drugs that have come up in less than 2 years. And now, if we can continue to reinforce investment in research in lung cancer like we should, then we're going to continue to see those changes. On the other end of the spectrum of lung cancer, when it comes to finding this disease, I mentioned risk factors. So we look at age and we look at tobacco exposure. Typically, we're looking at patients today. This year, recommendations changed to broaden the scope of who should be screened for lung cancer. We're supposed to be in our primary care offices or any of the other healthcare providers that we bump up against. We should be thinking about patients between 50 and 80 years old who have at least a 20-pack year history of exposure. The way I think about it is, if you've smoked for 20 years, you probably have a 20-pack year exposure. So you should talk to your doctor about that. If you've smoked a lot, you should talk to your doctor about it even earlier. And so I think the important piece is that we want to make sure that more and more patients are coming in for lung cancer screening, because when we find this early, surgery is more effective, targeted radiation may be effective in patients that can't undergo surgery, and the results are much better. And so we have a real opportunity to, I've always enjoyed the opportunity to operate on patients that have early stage cancer and see them in the clinic for years to come. And they're friends of mine, and they are patients that I look forward to seeing in the clinic. And I see them for various reasons. We follow up on their health. We follow up on their looking for any recurrence of disease. We look for new cancers that may show up. And we continue to talk to them about risk factor modification and what we can do to help them in an empathic way get to effective treatment. And it also is a conversation that goes on with their family, because maybe we can affect tobacco exposure, or maybe we can affect understanding that everyone with lungs can get lung cancer with more than just that one patient. And so I think that it's important that we understand that there's more to lung cancer than just someone who smokes. There's more to lung cancer than just older people. There's more to lung cancer than the previous knowledge that the likelihood of a long-term survival is low, because we're changing all of that. We're changing that. And so that's why this year's Lung Cancer Awareness Month, and we're thankful to Governor Beshear for recognizing this last week, and for the American Lung Association for their efforts in driving this message forward, because we have a lot to talk about. We have early stage successes. We, as Shannon mentioned, Kentucky is now second in the nation in terms of actually capturing patients who are eligible for lung cancer screening in that treatment or in that diagnostic CT scan, better than most of the country. And that's outstanding. Since we carry the burden, we should carry the responsibility of bringing in those effective treatments. We also are expanding the use of biomarker testing and the genetic testing that should be done. And we're finally bringing forward more of a message that that it's not just tobacco. Radon's a factor, family is a factor. We need to bring in the conversation and make sure that this isn't something that we don't talk about. We need to be able to bring it to something that we actually encourage our patients to talk about, encourage our primary care physicians and other providers to talk about. And so I think that that's the hopeful message that I see this year. And it feels so much different than it has in the years past. So I think that Kentucky's doing a great job of being able to be recognized in the country for the efforts that are going on. And I think that we've got a long way to go, but I think that we're seeing the benefits of the hard work from folks on this call, the folks that are also watching. So we're certainly looking forward to continuing that. Shannon, I'm going to turn it back over to you and look forward to further conversation with these folks.
Thank you so much, Dr. Mullett. And that was a hopeful conversation. We do have so much ground to cover and work to do, but I appreciate all of your work and your focus today. And if we can now shift specifically the conversation to radon in particular, because we know that most folks are aware of those risk factors associated with tobacco, but I think we have a lot of education to do as it relates to radioactive radon exposure. And so I would like to hand the conversation to Kyle now, who is our expert in that area. Kyle.
Thanks, Shannon. I'm going to apologize in advance. I'm a little hoarse. I'm coming off of an illness, so bear with me. And thanks to the work that the Lung Association does, specifically in regard to radon. I know we've made a lot of strides over the years here in Kentucky, and we couldn't do that without partners like the Lung Association. I'm going to start just by going back to something Lindi said, and that is anyone with lungs can get lung cancer. And before I get to radon, lung cancer has impacted my family as well. So, my dad passed from radon several years ago, actually almost a decade ago. And I had the unique experience of seeing the firsthand impact of radon. A lot of lung cancer survivors who are diagnosed, who are non-smokers, they really don't know much about radon. And I did. So having grown up in southern Ohio on a tree farm, we owned trees, and my dad was a forester and he was a non-smoker. It was a shock when I got that call that my dad had lung cancer, and we lived in the same house. So Dad was in early 70s when he was diagnosed, and he was gone 6 months later. And we did have a radon value on the home, and that was 29.6 picocuries per liter of air, which is quite high. And I'll give you a radiation dose equivalent here in a few moments. And then I was diagnosed with cancer about 6 months after Dad. And it was testicular cancer, and not a lot's known about that. But if you dig into the materials, there is some theory that radiation exposure could be a cause of testicular cancer as well. So it's just interesting, to grow up in that environment and then both be diagnosed with different cancers within 6 months of one another. And I often wonder if, my cancer was related to radon exposure as well. But anyone with lungs can get lung cancer. And, Lindi is a great spokesperson. She does wonderful work, and Tim and Alan. It's a good group, and we're fighting the good battle here in Kentucky, and we have made strides, as Tim said. So with that, I'm going to fill in some of the details that you may or may not know about radon. Radon is a naturally occurring radioactive gas, and it comes from uranium. So uranium over hundreds of thousands of years, even millions of years, breaks down into radium, and then we end up with about a 27-minute period where once radium becomes radon, we end up with a couple poloniums and 3 different types of radiation release, alpha, beta, and gamma particles. The alpha particle is the most significant one because it's significant enough that it'll actually dent plastic. And so when you inhale that, it has the ability to impact the lung tissue and the lung cells, and that's where the mutation comes from, and ultimately that ends up in lung cancer. It's measured in picocuries per liter of air. Right now, if you go outside in our state, you're going to be exposed to about 0.4 picocuries. It is naturally occurring, and it is in the background. The problem arises when we put a building on that land and the gas then becomes trapped in the building. So the gas enters the building through preferential pathways, gaps, crevices, sump crocks, things like that. And then just the air changes in the building slows that, and that's where it becomes trapped, and then we are exposed to that. Energy efficient building practices are actually exacerbating that problem. So as our energy efficiency becomes greater, the indoor air quality concerns, radon being one of the most significant, becomes greater as well. And we need to do a better job of understanding the impact of the indoor air environment along with energy efficiency and making sure that those two are harmonized so we're not making people sick because we're saving on the energy efficiency side of the equation. Here in Kentucky, we have quite the radon problem. In eastern Kentucky, we have mountains. Here in central Kentucky, we actually set over the largest cave formation in the world, and that is what exacerbates our problem. Without any resistance soil in these caves, you take a day where a thunderstorm comes through, for example, you get a barometric pressure change, and that pressurizes the cave system and it pushes the gas up into these buildings. And it can vary greatly. For example, here in Louisville, we have a house that in August will test somewhere between 1.8 and 2.5 picocuries. And if you go back and test that same house in December, it's going to test somewhere between 28 and 32 picocuries. And that's because there's a preferential pathway and a big sinkhole depression from our karst geology in the backyard. So it's important when we're talking about radon in Kentucky and Tennessee and northern Alabama over that cave system that we talk about when you test. We should be testing in the heating season and the cooling season, and unfortunately we don't always do that because so much of this is real estate driven. So we have some work to do to make sure that we're characterizing our buildings correctly. Radon is a Class A human carcinogen. It's known to cause cancer. It is the leading cause of cancer among non-smokers, second overall to smoking. And a troubling statistic is we're seeing lung cancer among non-smokers on the rise. Back when I started this radon thing 15, 18 years ago, it was assumed to be somewhere around 9 to 12% of non-smokers were diagnosed with lung cancer. And today, that number has creeped up, and you see as high as 15 to 18%. So smoking is on the decline, but lung cancer among non-smokers is actually increasing, and that's what we need to prevent. According to the US EPA, about 21,000 annual lung cancer deaths are attributable to radon exposure. I would suggest that that number is low. It just hasn't been updated. I've done some number crunching with a colleague at the Lung Association, and we've come up with a little closer to 30,000, but that's not for publication. Roughly every 25 minutes, someone dies because of exposure to radon, and that's unacceptable in my opinion. Synergies exist, and you'll probably hear Dr. Hahn talk about this, as you did Dr. Mullett, between smoking and radon. And I'll just fill in the blank that your risk factor is about 10 when you have the synergy between smoking and radon in that indoor air environment. To bring this home into something, a lot of times, well, what's 4.0 mean? What's a picocurie? So the radiation dose equivalent to 4 picocuries, which would be the level at which the EPA would suggest that you mitigate the home for exposure. At that number, that's the equivalent of getting up every day, Monday through Friday, running through to get your Starbucks coffee, and then heading to your local urgent care facility for a chest x-ray. That's the equivalent of doing that every single day that you go to work, 200 times a year, more or less, or smoking approximately 8 cigarettes per day. It's linear, no threshold. And what that means is the higher the number, the more you're exposed to it, that risk basically follows that line. So it is a high radiation dose equivalent that we're talking with. Kentucky, and many of you have probably seen the most recent report coming out from the Lung Association on the state of lung cancer. And Kentucky leads our nation in lung cancer incidence and mortality. Smoking isn't the only reason. According to the US EPA, the average radon concentration in the building is going to be about 1.3 picocuries per liter of air. Here in Kentucky, we are at 6.7. So pretty significant increase over what the national average would be. As well as the number of buildings. We talked about preferential pathways. So the EPA would suggest that about 7% of all buildings in the country have a radon problem. Here in Kentucky, that number is close to 42%. So big factor increase. And in many areas of our state, highly populated areas, for example, over in Tim and Ellen's neck of the woods in Lindi, it's almost 60% of all the buildings. Here in Jefferson County, 56% of all the buildings. In some areas, that number is as high as 65%. So lots of radon, high levels of radon. The highest concentration of radon that I'm aware of that we've tested in the state is 1,750. It was over by the Louisville Zoo, which has a large cave under it. And interestingly enough, that home had been in the family, and we could trace lung cancer back almost 4 generations in that particular home. So a lot of correlation there. If we look at radon-induced lung cancer in Kentucky, it's about 700 new lung cancer incidents per year. And about 500 deaths that would be attributable to radon exposure out of that larger lung cancer group. From an economic standpoint, that's well over $150 million economic impact, which is still insignificant when you compare that to the family and just the overall impact on survivorship. But it is a pretty healthy number when you talk about that burden on our health care system. So we do have a serious problem in our state. The good news is the problem can be prevented, but we need better policies in place to help make that prevention effort reality. Each year we build about 15,000 new residential units in Kentucky. Because we do not require passive soil gas control systems as part of the building process. Every year the radon problem actually gets worse, not better, because about half of those are going to have a radon problem. That's one issue. We have no policies to protect our children. No school testing, no child care testing. To me, that's almost criminal to expose young lungs to high concentrations of radon. We have no policies to protect our elderly living in nursing homes and assisted living facilities. That That's a problem as well, not to mention the folks that work there, our nurses, our healthcare providers. I see all the time when I drive around Louisville, healthcare heroes work here. So let's start treating those folks like healthcare heroes by making sure that the air that they breathe is healthy and safe. We have no policies to protect our workforce. You get up and you go to work. Do you know what's in the air that you're breathing? Probably not. Maybe we should start asking those questions and holding our employers accountable for a healthy and safe indoor environment. We do have one policy, and that's an informational statement that's included on the seller disclosure form. Most of us on this call worked on that in some capacity, and I'd like to think it's successful. In other states, it's been successful, but quite frankly, the state doesn't gather the information it needs to. So we really don't have any data to understand if this policy is having a meaningful impact or not, and I hope that changes. And finally, we have a problem with access to radon testing and mitigation in our rural areas, as well as a health equity challenge in our low-income communities, which Dr. Hahn is going to expand upon now. So Shannon, that's it for me, and I will turn it back over to you.
Thank you so much, Kyle. I bet we have some questions, and we are going to try to save time at the conclusion of this discussion for questions. So folks, be thinking about that. But Ellen, if I can ask you to pick up the conversation here and talk about those disparities in rural areas of Kentucky, I'd be grateful for that.
Thank you. Thank you, Kyle, for the ball. I'm catching it now. So for those of you that don't know me, I'm a nurse, a public health nurse. And while I do not have lung cancer in my family, thankfully, I tell people I was a smoker till I was 18 because both my parents smoked, and I lived in a rural community in Appalachian, Pennsylvania. So I do have severe lung issues. I'm an asthmatic and an early COPD patient. So this is important to me. And so as a nurse, our focus at Breathe at the College of Nursing at UK is really prevention, totally prevention. And my goal today is to share with you some things we're learning. And one is disparities in radon-induced lung cancer, and one is sex disparities. The reason I moved from tobacco control research to radon research is because I realized that 15% of lung cancer cases are in men and 23% in women are not caused by smoking, firsthand smoking. So what that really means is that of the 600 to 700 new radon-induced lung cancer cases each year in Kentucky, most are in women. And so that's very concerning. Another disparity, of course, is socioeconomic status. So individuals with low socioeconomic status are more likely to get lung cancer and die from it. This disparity is also true with historically marginalized Black, Indigenous, and people of color, who are often low socioeconomic status as well. So given these disparities, indoor air contaminants like tobacco smoke and radon in the home are of particular concern to many of us, and particularly in rental property and multi-unit housing, public housing. However, our research has shown us that landlords often fear any policies to restrict smoking. I can't say that we've done this work yet with radon, but there's a lot of research about how landlords fear smoke-free policies will hurt their business. But multiple studies really show that landlords with smoke-free policies in multi-unit housing are actually less likely to report vacancies and turnover compared to their counterparts that do not have these policies. So my guess is if there were radon policies related to rental property, that it would be okay. And in fact, the public would want them, and that we wouldn't see reduced business. Just a word about co-exposures. Kyle already said this, but I just want to emphasize the importance of radon as a risk factor for both smokers and non-smokers. He already told you the tenfold effect, and that is true. So if you're exposed to both, we call them in the environmental health world co-exposure. So if you're exposed to both radon and tobacco smoke, your risk is nearly tenfold. And, not only do we have these disparities with radon, but we also have these disparities with tobacco smoke exposure. So people below the poverty line and those with less education are significantly more likely to smoke and less likely to attempt to stop. And similarly, secondhand smoke exposure is a major source of indoor air pollution, especially those of low income and those that live in public housing. Unfortunately, the environmental risks that exist in the home, and particularly in rental property and multi-unit housing and public housing, are not readily acknowledged by those who rent, who live there, nor those who can provide the solutions, meaning the landlords and the property owners. So I want to move to radon testing disparities. So there are disparities in radon testing as well, related to what we call the social determinants of health. And so there are research studies looking at lower income, lack of home ownership, lower education, and rurality have all been linked to rates of radon testing. And in fact, our team just published a study, and Dr. Stanifer was first author, thank you, Stacy, found that Kentucky counties with lower median home values have lower rates of radon testing than those with higher median home values. So for each $10,000 increase in the value of your home, there's a corresponding increase in annual rate of testing of households. So that's concerning, though. So that just shows you the disparity. So in the chat, I'm just going to give you the link. Many of you know that we have radon, county level radon geological maps that show disparities in radon potential, mostly related to differences in the underlying geology in Kentucky. And so if you click on that, you'll see actually that there's a ring of red. Red is really high, but actually the colors on those maps, most of Kentucky has really high radon risk potential. We did a study, though, with renters, and our team found that almost 6 in 10 renters are interested in testing their home for radon. They have tested their homes when we gave them free radon test kits at the primary care setting, and they appreciated getting the results back. However, they were really worried about their landlords being unsupportive and not willing to fix the high radon levels due to cost. Some expressed fear to us in sharing their results with their landlords, worried that they might have to move if they told their landlord. But our work shows that, or I would anticipate, and the glass is always half full with me, my mother taught me that if we provide information to landlords about the environmental impacts of radon and the access and provide access to affordable radon mitigation, they may be more likely to actually attract future tenants and support healthy homes. We clearly need more research with landlords and property owners. So a couple words about radon mitigation disparities, because there are many. Radon testing without access to affordable hazard remediation for high levels, in my opinion, and many people around the country, is a serious environmental justice issue, as Kyle mentioned. And so low socioeconomic status population have limited remediation options. They can rarely afford to install a radon mitigation system. I think Kyle may have mentioned to you that mitigation costs range in Kentucky from about $1,250 to $1,750 for an average home on a basement, and up to $2,500 to $3,000 for a home on a crawl space. And so that is expensive for many people, and the costs are higher for multi-unit housing. But the real point is that the cost of radon mitigation and the power to fix the problem are significant barriers to lowering environmental risk for lung cancer, especially among those low SES populations. Unfortunately, there is an inconsistent radon control legislation across the country, and very few states or locales that attempt to achieve equity in radon mitigation. And I guess the shining star for me is always Colorado, because Colorado in the last few years, state legislature approved funding to create a financial assistance pool for radon mitigation. I think it is sad, though, that the EPA's SURGE program, which is the State Indoor Radon Grant Program, cannot be used to provide grants or loans or direct mitigation services to homeowners. And hopefully we'll see changes in that, but that is a concern. And lastly, our team has been trying to identify a menu of options for people who cannot afford radon mitigation. And there is interest in Kentucky in the affordable housing industry to provide loans and grants for radon mitigation. However, currently the infrastructure does not exist, but we're working on that. We've talked with housing corporations around the state who are interested in helping homeowners and low-income families access the grant program, for example, the Carol M. Peterson grant program, USDA grants and loans. We've talked to the USDA office in rural development here in Kentucky, and they do have a home repairs program that could be used for radon mitigation. We've talked with Habitats for Humanity, who are very interested in working with us and using their home repair funds for radon mitigation. And then we've also learned a lot from others around the country. The HUD has a home investment program, partnership program called HOME. And I know New York State recommends the use of these funds for radon mitigation. So we don't have the answers, but we're surely working on them. And I am really, really concerned, though, not only for all of us who can afford radon mitigation, maybe, but those who can't. And so, you know, I'm hoping we can share more with you, maybe as we have conversation, Shannon, about some of the kind of innovative things that we're doing to increase access to radon testing and radon mitigation in rural Kentucky, particularly through our libraries and our pharmacies. Thank you.
Thank you so much, Ellen. Both you and Kyle, I'm sure, have raised questions in participants' minds. So I want to take a beat now to, and not just in the radon space, but generally for all of our speakers, to allow participants to ask some questions. I see Kathy's hand raised already. So Kathy, I'd like for you to begin, please.
Yeah, okay. So thank you all very much for, and this is extremely informative and from Lindy's standpoint, heartbreaking, but it just reinforces the need for what we do every day. Dr. Mullett, I was curious, you did talk about, you know, the higher rates of screening now and for the low dose CT scan, which that was how my lung cancer was detected before the insurance covered it, which is kind of my question. I would not have qualified under any of those criteria. What are we doing to, I guess, look at other screening that are not quite as invasive and not invasive, but they're not quite as expensive? I know there was some talk about a saliva test. Are we looking at, are there some other screening options that are on the horizon?
Well, there are, you know, and I think that we've already seen since the time that the lung cancer screening by low-dose CT scan was approved in 2015, and it received a grade B by the U.S. Preventive Services Task Force. So that means that it's covered by all of the Affordable Care Act compliant insurance plans from the first dollar. And so, you know, it doesn't cover diagnostic work that may follow a scan, but that's something we're working on with policy. But I think the fact that it's covered has been a great advance for over 6 years now. And this year we've expanded those criteria based on more data. And I think those are the studies. The first study we had was ages 55 to 80, and it was based on the National Lung Screening Trial that completed in 2010. And, you know, so that was great information. Big study, a lot of information, solid data to be able to get to the screening criteria. new studies, international studies, and follow-on studies from the national lung screening data have given us the opportunity to expand that to 50 to 80, and to be able to lower the tobacco exposure criteria to 20 pack years instead of 30 pack years. So those are good for us to broaden the net, so to speak, to capture more patients that might fall into the opportunity to detect based on those relatively blunt instruments of smoke exposure and age. We really do need to get to a better criteria. And I think as we examine patients that are going through lung screening and identify those cancers as they come along, we're doing more in terms of evaluation of genetic testing, and so that we might be able to get to a genetic profile that will be much more specific, that would be age independent and would be able to tell us whether or not a patient is at risk. But for right now, we have only those criteria, age and tobacco exposure. There have been studies that have been looking at saliva, have been looking at a revisit of a very old technology of looking at sputum cytology, which where we would look and see whether any cancer cells come up. That was something that was tested many years ago, not shown to be effective. Lung cancers were not found in an early enough stage, so sputum cytology didn't help. But with more specific fingerprinting, if you will, of cancer cells, then maybe we can be more sensitive in our sputum cytology. So there's examination of that. There's also a look at something called exhaled breath analysis, where we collect air that comes from patients to be able to see whether or not there's any markers that we can use as a early indicator or an indicator of lung cancer. So, I think that basically what we need is more research. We need more dollars. And I think that's one thing that I think needs to be clear here, is that all of these, you've heard about radon, but yet you didn't hear about radon being included in a risk factor for an approved indication for getting a CT scan. And that's because we need more data. The work that Dr. Hahn's doing, the work that others around the country are doing, to be able to give us that information so we can put that into those categories that say, these are patients that should be tested. And so, unfortunately, lung cancer, because of many reasons over the years, has been underfunded compared to the number of deaths that are caused by lung cancer. A fraction of research dollars spent on lung cancer compared to that spent on breast cancer, or that spent on even colon cancer. And so hopefully we're going to see that change. In Kentucky, we used to have from the Master Settlement Agreement, a dollar amount that was delivered to the state for lung cancer research. I'd like to see that reinstated. I think that that's something that we ought to bring back. And I think that it's an opportunity for us to be able to continue the research that we need to do. Again, it's our disease, it's our cancer, it's our responsibility. I think we need to respond to that.
Thanks very much, Dr. Mullett. So this transitions the conversation a bit to the policy space, and we have just a few minutes left. I would like to speak a little bit about what our policy focus is going to be in the upcoming session of the legislature, which will convene in January 2022, as it relates to tobacco and as it relates to radon. Specifically, as it relates to tobacco, we will be working to increase funding for the state tobacco prevention and cessation program. And so we have seen that funding erode over recent years. It is now at $2 million, and CDC recommends $56.4 million for funding in Kentucky. We have a lot of work to do there. And we will also be talking about radon as it relates to testing in schools, K-12 schools. We're working now to identify a bill sponsor who might be able to help us make some advances there. And I want to acknowledge and recognize Kyle, Lindi, and Dr. Mullett for joining in that advocacy conversation with our potential sponsor a few months ago. And so additionally, related but not in a legislative forum, the Lung Association is working to help educate realtors about that addition that Kyle mentioned to the residential seller's disclosure form that recommends disclosure by the seller in the event that testing has been done in a home. And so the Lung Association, through a grant, has contracted with a marketing firm here in Kentucky who will be launching in January, which is Radon Action Month, a mass communication plan targeting real estate professionals to educate them so that they can educate their clients about the importance of radon testing and mitigation. So just to put that last ribbon on our conversation, I want to first thank all of our presenters today. Each of you did a fabulous job. I appreciate you, and I want to turn things back, if I may, to Lindi to conclude our last 2 minutes of this conversation. Oh, Lindi, you're on mute.
Sorry about that. I'll make it quick. My husband hates my analogies, but since we're finishing up football season, I'd like to say, you know, we're all on the same team. We're fighting against what seems like an unbeatable opponent, but we all have a role to play, just like in football, whether you're the head coach, the assistant coach, whether you're on the offense or the defense, whether you're a fan, whether you're taking care of the facilities. We've learned here we all have different roles to play, whether you're fighting for policy, whether you're trying to educate people about radon, whether you're trying to stick up for the survivors and help people understand anyone with lungs can get lung cancer. What is your role, and are we really doing enough to beat what seems like an unbeatable team? But we can celebrate this. We can get excited about the small victories, a touchdown here and a 2-point conversion, little things like that, just like we can when we see some advancements in screenings and stuff like that. But we can't stop there. We have to help one another. We have to work as a team. We have to know that it's going to take all of us to beat this, what seems like an impossible feat. But it's exciting to hear the things that are happening. But when you're on the survivor side like me, it's not enough. It's not fast enough. It's never enough. And it's urgent that we keep these conversations going. I just knew, because I felt like I was going to live longer than most survivors, I had to keep the momentum going. Much like Kathy, we're so much more fortunate than so many other people. So let's keep the momentum, keep this these issues urgent at the top of our list, and just work together as a team to eventually see if we can beat it.
Thank you, Lindi, and thanks to all of you for joining the conversation today. If you're willing to be an advocate engaging in public policy with the American Lung Association, please drop your name in the chat. We need your support. Thank you to all of our presenters and participants. Bye-bye.
Bye.
Thanks, Shannon.